End of life care. It is a medications review, elimination of unnecessary medication. Then the PRN, as needed medications with appropriate parameters. Essential interventions, limiting blood draws or invasive interventions. Communications, when or for what the family wants to be contacted. Spiritual culture rituals awareness. End of life symptoms. Symptom management and minimizing the resulting suffering is cornerstone for the quality palliative and end of life care. Patient with end life limiting disease often will need management of their pain, their dyspnea, their poor appetite, depression, constipation, and agitation. Somatic pain arises from musculoskeletal system and is described as aching, stabbing, or throbbing. Treatment is usually NSAIDs, non-opioid drugs. Visceral pain arises from internal organs and described as cramping, pressure, dull, or squeezing pains. Treat with anticholinergic meds or opioids. Then there is a neuropathic pain arises from the nerves and nervous system. It is described as tingling, burning, or shooting pain. These are usually treated with anticonvulsants. This is a tool that is used for the pain assessment. It's universal pain assessment tools from 0 to 10, 0 being no pain and 10 being the worst pain possible. And then there are we have a verbal descriptor scale, we have a Wong Baker facial grimace scale, and then activity tolerance scale. Pain assessment in advanced dementia scale. This is PAINAD. This is used. This is scale. First, we look at the behavior of the patient, and first, like look at the breathing. Assess how the patient is breathing. Is independent of vocalization. um, if the patient is breathing normally, we will give a 0 point. And then if a patient is occasionally labored breathing, a short period of hyperventilation, that will give him 1 point. And then noisy labored breathing, long period of hyperventilation, or Cheyne-Stokes respirations, 2 points. Looking at the vocalization, if the patient negative vocalization, none, 0. Occasional moans or groans, low level speech with a negative or a disapproving quality, 1 point, and repeated troubled calling out, loud moaning, groaning, and crying, 2 points. Looking at the facial expression, if the patient is smiling or he's inexpressive, you give 0 points. 1 point for a sad, frightened, and frown look, and 2 points for the facial grimacing. Assessing the body language, if the patient's body language is relaxed, 0 points. Patient looks tense, distressed, pacing, and fidgeting, 1 point. And if the patient looks rigid, fists are clenched, knees pulled up, pulling or pushing away, streaking out, 2 points. Consolability. If there is no need to console, 0 point. Distracted or reassured by voice or touch, 1 point. Unable to console, distract, or reassure, 2 points. This can be used in the patient who have again dementia and they're unable to appropriately let the provider know how much pain they are in. Scoring is a total score ranges from 0 to 10 points. A possible interpretation of the score is 1 to 3 will be mild pain, 4 to 6 moderate pain, and 7 to 10 severe pain. These ranges are based on the standard of 0 to 10 scales of pain but have not been sustained in the literature for this tool. What is dyspnea? This is a subjective breathlessness. It can be triggered by primary lung disease, but it can also be related to other organ diseases. It can also be related to pain, discomfort, and anxiety. Subjective scale measurement can be used to trend symptoms or track triggers. Objective measures are to look at patient's respiratory rate and the patient's oxygen saturation. So, how do we treat patient with dyspnea? We gave a patient oxygen therapy, ambient air therapy, cooling fan, opioids, bronchodilators, corticosteroids, and diuretics when clinically indicated. Poor appetite is another symptom. Loss of appetite can be quite distressing for caregivers and family and friends. In many cultures, food is associated with caring and comfort. In late stages of illness, caregivers can often voice concern as a patient deteriorates that they are declining because of lack of food. Reassuring and educating should be given by patient's healthcare team explaining it is expected in the course of death. Feeding via enteral feeding does not clearly prolong life, improve quality of life, or decrease aspiration in terminal patients. High calorie supplements and pharmacological appetite stimulants are not recommended and they come with their own side effects. Poor appetite causes multifactorial. It could be side effect of the treatment, side effect of the medications related to patient's nausea, constipation, symptoms related to depression, fatigue, dry mouth, progression of the disease, and associated lack of hunger as eating becomes burdensome. Depression is another concerns to be taken into consideration. Studies have shown that depression is an independent predictor of mortality in patients with a coronary heart disease. Meta-analysis studies of the cancer patients suggest depression may be utilized similarly to the predicted mortality. In this review, those with depressive symptoms had a 26% greater mortality, and those diagnosed with a major depressive disorder had a 39% higher mortality, an effect that was independent of other risk factors. Support and assessment from psychiatry and psychology members of the palliative care team may provide vital interventions for coping and reconciling challenging process of dying. Depression can be treated with CBT, cognitive behavior therapy. It could also be treated with a pharmacological treatment, which could be psychostimulants because of their rapid onset of actions, are useful agents, and are generally well tolerated. SSRIs, selective serotonin reuptake inhibitors, and tricyclic antidepressants may also be used. Another symptoms, constipation. It may present as an agitation. So causes could be the patient is dehydrated, patient is immobile, patient sometimes are on opioid for a pain control leading to constipation. Objective evaluation, look at the patient, have a physical examination, especially abdominal and rectal exam. We could also do an x-ray of the abdomen. Treatment, it could be laxatives, enema, and bowel stimulants. Agitations. Often agitation arises due to untreated issues causing the discomfort that we have mentioned. Careful evaluation and examination may reveal the underlying cause. End of life is also associated with terminal agitation and delirium, in which no clear classes of the medications can be shown to be a preferred choice. However, benzodiazepines and phenothiazines have some effect. Diagnosing dying. Clinicians are not often well trained or comfortable in diagnosing dying. Studies have shown that patients with a life limiting diagnosis prefer to be informed of such information to cope with their circumstances. One study in the UK showed 49% of the patients were recognized as dying 24 hours or less before the death. 17% between 24 to 36 hours before death, 21% between 36 and 72 hours before death, and 13% greater than 72 hours before death. Often, the diagnosis of dying is difficult and made close to the time of death, in which patients cannot benefit from the end of life care preparation. Instead of attempting to improve the accuracy of diagnosing dying, it is more logical to promote systems where palliative care objectives are incorporated with ongoing care. Bereavement. Provisions of bereavement care is required as part of the Medicare hospice benefits. Bereavement support is available to family friends for a patient for 1 year, 1 month past anniversary of their death. This can take a form of psychological therapy or a follow-up calls and visit to provide emotional support for those after the patient has passed.